Mind Deconstructed, Mental Health and Wellness with Dr. Kaz and George.
I'm Dr. Kaz Nelson, an American Board of Psychiatry and Neurology certified psychiatrist licensed to practice medicine in the state of Minnesota.
I'm your podcast host, George. I'm a licensed attorney in the state of Minnesota, but I'm not here to give you legal advice.
The statements of Dr. Kaz and George are not a substitute for medical care, and our opinions are our own. If you are experiencing a mental health emergency, please seek assistance from a professional.
You can contact us on Twitter at Mind Deconstruct. On today's episode, Kaz's beef with Benzos. Welcome back to the Mind Deconstructed. We're going to call it Season 2, Episode 1. How do you feel about that, Dr. Kaz?
I'm so delighted to be back in recording. We took a break between last fall and now with recording, and so now we're back with Season 2, and it feels good.
Yeah, so this is Season 2, and we're going to roll right back into producing hopefully 2 episodes a month for
or
the
one
for the foreseeable future. Obviously, Kaz and I both have other things going on besides this podcast, as much as we enjoy putting it together. So we're rolling right back into it with Kaz's beef with Benzos. Are you excited about today's episode?
Yes and no. It's something that I think is critically important to talk about. It's also difficult to talk about, and I think there'll be a range of reactions to what I have to say. And so I'll be honest, I'm a little nervous about that, but I do feel like we should talk about it.
Okay, well, let's roll right into our hot topic in mental health. 2 hot topics for today, the first being Minnesota Mental Health Advocacy Day at the state capitol, and that was last week.
Right.
So that'd be the second week in March, right?
Yep. The second week of March, 2019. And there were people from all over the state, despite the fact that it's difficult, flood-laden weather in Minnesota right now, came to the state capitol and spoke with their legislators and put their support behind some important legislation that has a chance to impact the health of Minnesotans.
Yeah, so the legislature is in session right now, and so they were getting out there and making themselves known and available and trying to get their issues on the table for these legislators.
Absolutely. And I think there's been a lot of interest in advocacy, increasing interest in making one's voice heard, and some lowering of barriers on how to do that. And so that's been fun to really see people get excited about this effort and be empowered to actually connect with people who make the laws.
Yeah, and there's certainly no doubt that mental health and the associated groups are in need of funding and mental health beds and
right.
Just, more support from legislators at the state level and probably at the federal level too.
Our mental health system absolutely needs to be improved, and the people who make the laws need to hear from experts in this area, people who are impacted by laws that don't work, so that they can do the right thing.
Our second hot topic in mental health for this week is National Match Day yesterday. This is going to be of interest to those listening who have an MD after their name.
Right. Well, really anyone who has seen a doctor or wondered how a doctor gets their training, there's this very interesting system in the United States where people get accepted to a medical school and do 4 years of general medical training, but usually all graduates of medical school then go on to do another 3 or sometimes up to 7 or 8 or more years of specialty training in a certain area of medicine, like obstetrics and gynecology or neurosurgery, or in my case, psychiatry. But in order for people to know where they're going to go to get that training, they have to list their preference of places they want to train, and different training programs actually interview and list the applicants that they'd be willing to have in their training program or excited about it. And a computer algorithm matches these applicants to a training program. And there's one magical day where everyone who's successfully matched gets together and opens up an envelope and learns where they will be living for the next 3 to 7 years.
It's
pretty remarkable.
It's still a physical envelope?
Yeah.
They get it in the mail, or do you hand it to them at their medical school? How do they get that envelope?
Well, I think it's both at this point. There is an envelope, and usually people at a medical school will gather in some type of ceremony and open up the envelope together. And then a few minutes later, they usually get an email with the information in the email.
That sounds excruciating.
Yeah, particularly for the time between when that list goes in and the time the envelope's opened, there's really nothing you can do to change your fate. And in some cases, you maybe put training programs in California or Texas or North Carolina on your list, and you're going to learn where you're going to need to pack up and move between now and June.
Has anyone ever pointed out that match day is MD and you guys are all MDs?
Well, there are trainees who are doctors of osteopathy who have a DO after their name, but you're the first person who's actually pointed out that commonality to me for the MD students. So
I think we could make posters for next year.
Right. Yeah. You might be onto something there.
Except that's really not nice to the DOs, I guess.
Yeah. We want to be inclusive.
Yes. So, Dr. Kaz, benzodiazepines, that's a word that a lot of people probably aren't super familiar with.
Right. It's actually referring to a class of medication. And there are over a dozen different medicines that are in this class.
So what are some of the common names of medicines that, just so we have a frame of reference for what we're talking about for people who may have heard of these things in pop culture or from their medical provider?
Sure. And normally I like to just use generic terms of medications because I'm not looking to endorse or promote any kind of brand name. But I will share both the generic and the brand name with you just because these are common medicines and they're usually more commonly known by the brand name. And I want to make sure that you all know that we're talking about the same thing. So medications like alprazolam, clonazepam, diazepam, or lorazepam. Those are the generic names. They often end in PAM. And then the brand names would be things like Xanax, Klonopin, Valium, or Ativan. And just so nobody gets confused, there are some other medicines that end with AM, like citalopram, otherwise known as Celexa, is a antidepressant and doesn't fall in this group. So I'm not talking about citalopram, just talking about Xanax or Klonopin, Valium, Ativan, or there's other medicines too.
And so if we refer to them as benzos, that'd be accurate for the rest of this talk?
Sure, that's kind of a nickname for this class.
What do benzos do to the body?
Sure.
Why are they prescribed? How do they react to the body, and what do people feel when they're on them?
Basically, benzodiazepines help you feel really calm. They work on a set of receptors in the brain that allows a neurotransmitter to flow a little bit differently than it would have otherwise. And the ultimate result is that sense of anxiety, even a kind of a panicky sense, goes down.
These are the things that in movies and in other places you hear someone say like, oh, take a Xanax, to people who are feeling anxious or,
Yeah. Why there's so many of them is that some act for very short term, like you might take it and a few minutes later feel very calm for a short period of time. Or there's other ones that are a little bit slower acting, so you might feel a little bit less calm, but for longer, if that makes sense.
How common are these medications out there?
That's why I think this is going to be a controversial topic, because these medications are prescribed very commonly. And in fact, there was a recent study done last December that estimated over 30 million U.S. adults took benzodiazepines in the past year. And that includes 5 million who took these medications in a way where they were not prescribed by a physician. But on the whole, the vast majority of people taking a benzodiazepine had it prescribed by a physician. So that translates to around 12% of people in the past year was taking one of these medications. And that includes a lot of people who might be listening to this podcast right now who might be on a medication in that class, taking it regularly. Once a day, 3 or 4 times a day, or sometimes it's prescribed as needed.
I've heard, in pop culture that, and in my line of work, people abusing benzos or Xanax or any of these things.
Yeah.
What's the goal? Like, are you trying to get high? Is that what can you get high on Xanax?
Well, one of the properties of benzodiazepines is that they're very chemically similar to alcohol. In the same way that if somebody were to take some alcohol and feel a little bit calmer a few minutes later, benzodiazepines work in a similar manner. And so I would say that whether somebody is prescribed these things or maybe got them from someone they know or even bought them from somebody who was dealing these as a drug. Generally, most people taking these are trying to survive their day, trying to survive how they feel, and are taking that medication to feel better or decrease some very painful, difficult anxiety or other feeling.
Okay, so it kind of decreases the what you might be feeling at the time.
Yeah, people use it as a way of managing very strong or painful emotions.
Is it prescribed for that purpose ever?
Yeah, that's why it's prescribed. Somebody comes in and says, I feel extremely anxious. I'm panicking. I'm crawling out of my skin. And completely well-intended, a physician will say, well, let me prescribe you something to make that feeling go down.
So there's a lot of medications out there that, have a potential for abuse. What's your beef with benzos in particular?
Yeah, why am I concerned? If this is a medicine that helps you feel better and people are not feeling well, why wouldn't we just prescribe this to help them feel better? Well, I actually wish it was that way. I wish it was that simple because as a psychiatrist, I'm pro-medicine. I'm pro-mental health. I don't have a bias against people using medication to treat mental health conditions. That's actually something that I'm very much in support of. But I'm very scared about this particular approach with this particular class because what I've seen and what a lot of other physicians and psychiatrists are reporting is that when people are on these medications over long term, and I'm talking like more than 2 weeks, it tends to cause a lot of problems and a lot of side effects down the line. And that's where the concern comes from. If this was something simple like, oh, you have an infection, so here's an antibiotic and treat the infection, that would be great. But unfortunately, it doesn't seem to be working that way. These medications impact the brain similar to how alcohol impacts the brain. And so over time, unfortunately, the brain starts getting used to this class of medication, and you need more and more and more of the medication to have the same effect. And so over the long term, it tends to make people sicker in the same way that if somebody was drinking alcohol every day, you might think, what's wrong with that? If it helps them feel better, why not drink alcohol every day? Well, over time, we know that people tend to function worse and have worse mental health when they use this strategy.
So if you're on a benzo for a couple of months and then you were to go off of it, would you potentially feel even more anxious?
That's right.
Would you associate that with a craving for more benzos, or would you just be like, oh my gosh, my anxiety symptoms are off the chart?
Yeah.
And then you go to your doctor and he prescribes you more benzos.
That's exactly what seems to be happening. People are on this and then they say, oh, let's try not using this medicine. They feel terrible because their brain receptors have really gotten used to that medication and they are upset. They said panic signals saying danger, we want more of that medication. And that leads to a sense of heightened anxiety. And oftentimes people make the mistake and interpret that to their own anxiety and not as a sort of withdrawal effect from this medication. And this medication class does have terrible withdrawal that can be life-threatening in some cases. But even at lower doses, being off of it isn't life-threatening, but it doesn't feel good. Your body craves it, wants it, and generates anxiety in a way that is not your true anxiety. It's a artifact of being off of the medicine.
Physiological or psychological?
Well, there's really no difference because the sensation of anxiety is in the body, and then the brain tends to come up with reasons why you feel anxious.
Oh, interesting. So like you have that physiological response and then your brain comes up with what you're worrying about later.
We've talked about that before, like when I overdo it on the caffeine in the afternoon and drive home and feel very stressed out and think about the terrible things in my day. And I say, why do I feel so bad and anxious? Oh, it's not because I actually had a bad day. It's because that caffeine I drank in the afternoon is sending these signals to my body that I'm anxious. And now my brain's trying to make sense of those feelings.
What about, is that true across the board? What if someone is using a low dose and they're not an addict, they're just doing what their doctor has prescribed them to do?
Right.
Is that
I assume that some of the people listening today are in that boat and probably feeling real defensive and saying, listen, I've used this at the same dose for 10 years and I don't have a problem with it and it helps me a lot. So what's your problem? Well, even in those cases, I do feel concerned and kind of sad about this approach, because if that same person said, well, I just take my, shot of gin or shot of whiskey twice a day to help me do better, and I've been doing that for 10 years, and there's not really a problem associated with that. These medicines do impact functioning. They do impact quality of life in a negative way, in the same way that alcohol does, where it's somewhat of a depressant. And so what I would love for those people is to actually slowly taper that medicine and engage in brain and body training to bring down that anxiety response in a way that is more sustainable, rather than this approach, which tends to make anxiety worse over time and lower functioning over time.
Anecdotally, I have seen persons who have had prior addictions who get prescriptions for benzos, and then, these are, this is what helps me, not use opioids or not drink alcohol. How do you feel about that strategy?
Yeah. Some people would call that a kind of a harm reduction strategy. Like being on this pill twice a day is a lot less harmful than being on heroin purchased off the street. There's a lot of common sense to say, yes, that approach is less harmful. But even for somebody like that, I would love to see them get their anxiety meaningfully treated in a way where their anxiety symptoms are going to get better over time, versus this approach where, when used over the long term, people tend to do worse. And for that person who maybe has issues with addiction or has used heroin or some of those other things, they need a lot of help and they're really, really suffering. And I would like to see them get meaningful help for that suffering, rather than this approach, which is sort of like using a strategy that feels good in the short term but makes things worse over the long term.
When would you prescribe benzos, or how would you prefer that they be prescribed across the board?
Well, I see this class of medication very similar to this class of medications that's often been talked about in the media, which is opioids. Those pain pills for which we have a serious epidemic in our society, and people are dying from this right and left. And it started out kind of innocently, doctors and other professionals prescribing these to help with pain, because we can all agree that we want to help with suffering. But this particular strategy of using opioids long-term to help with pain and suffering has actually destroyed a lot of lives and a lot of families. The strategy just doesn't work. And benzodiazepines are actually very similar. And I do worry that we do have a benzodiazepine epidemic in our country. And so what I would say is any kind of long-term or chronic daily use of this class of medications is going to be probably more harmful than beneficial for most people. Where I do use these is sometimes when somebody is experiencing extreme alcohol withdrawal. This class of medications can be helpful in treating that in the short term. We also use this with a condition that's very serious called catatonia, and it's one of the best, most effective critical treatments for catatonia. So if you know someone who actually had catatonia in the past and they're on a benzodiazepine long-term, that's going to be very essential for their health, because this condition is really mainly only responsive to this. Certain seizure disorders are treated with benzodiazepines.
But you're not saying generalized anxiety disorder.
No, I'm not including generalized anxiety disorder or even panic disorder in this class. And it's controversial to say, because there are many people who say, what's the big deal? When I go on a plane ride, I take my Valium. What's the problem with that? Well, the problem is that you have an impairment when you go on that plane, which might impact your safety. But more concerningly, when you take that benzodiazepine, your body doesn't learn that you actually survived that plane ride. It doesn't encode the fact that there is nothing to be that fearful about. And so that fear of flying actually goes up and up and up over time. This medicine doesn't actually treat that fear. It actually underlies it. And for any kind of fear-based strategy, the treatment is actually exposure to the item of fear and learning that you actually survived it and that you're safe. And using a benzodiazepine as needed in those moments works against that strategy.
So you're obviously very passionate about benzos. Anything else that people should know?
Yeah, I just want to let you know that depending on what you're hearing me say, I'm not saying that people who take this are bad or that people who prescribe this are bad. I think everyone's trying to survive their day and everyone's well-meaning. I just can't stay silent on this anymore because I've seen so many people get worse over time, function worse over time, who are sort of fooled into thinking that the medication is helpful when really over time they're doing worse. And ultimately, I took an oath to first do no harm. And I'm fully confident that when used in the long term, these medications are harmful. And so that's why I can't really stay silent anymore, particularly when a lot of these people who've died of opioid overdoses, if you look, oftentimes they were taking benzodiazepines or alcohol at the same time. And so I just worry that this is a dangerous issue that's been under the radar for too long and can't stay silent.
Our listener question for today actually comes from my wife, and it relates to what Dr. Kaz just said. She wants to know how people can seek treatment for maybe a benzodiazepine addiction. You know, if they are on benzos and they want to get off them, how would they go about doing that?
Sure. And I just want to be careful about your use of the word addiction there, because there are so many people who have been prescribed this medicine who wouldn't say that they're addicted to it. And I would never call them an addict or anything like that. But what this class of medication does do, I already mentioned this idea that the body sort of gets used to it and develops what we call a tolerance. And then those symptoms get worse and worse, and you sort of need more and more to have the same effect. And when you stop it, you feel bad or sick. So those are called tolerance and dependence. And those are things that happen to anybody who takes this. It doesn't mean that you have a drug addiction or anything wrong with your character or anything like that. That's a property of the medication itself. And so if anybody is taking these kinds of medications on a regular basis and saying, gosh, I'm sort of concerned about what this means for me, I would just encourage them to bring this up with their primary care provider or whoever may be providing psychiatric care and say, what would this look like for me to slowly come off this medication? And because it's so difficult to go down on this medicine, I actually recommend that if you can, you might even take a year to do it. So if you're taking 1 milligram of Klonopin 3 times a day, you might start by taking away 1/4 of a milligram just once a day in one of those doses, and do that for a month. And then take away another 1/4 milligram in the morning, and then do that for a month. Because if you don't go slow, you're going to have a rebound of anxiety symptoms. And it's very uncomfortable. And people say, I can't do it. I need that medicine back. And so take your time, go slow. There's nothing wrong with that. And if you go slow enough, your body will adapt over time and catch up and not miss it so much. And you might be surprised at the end of that year, you might find that your anxiety is well managed without it.
And work with your provider.
Yep, absolutely. Don't do this on your own because, like I said, depending on what dose you're on, stopping it suddenly can cause life-threatening withdrawal. And that's not anything you want. It can be dangerous. And so always work with someone who knows what they're doing on a benzodiazepine discontinuation project.
And we've talked about therapy plenty, but is there preferred therapy for someone kind of working through that downstepping?
Well, the most effective therapy for anxiety, which is the main reason that this class of medication is prescribed, is cognitive behavioral therapy. And if you listen to episode 2 of our podcast series, What's the Deal with Psychotherapy? We tell you about cognitive behavior therapy, what it entails. And it's so effective. It teaches your body to learn that it's safe, even when it's perceiving that there's a dangerous situation. But if you're afraid of spiders and you see a photograph of a spider and your anxiety goes through the roof, there's not actually a danger there. And so what cognitive behavior therapy will do will actually help your body realize there's not a danger.
And for those of you who haven't listened to our back catalog, you could go back and listen to all the episodes. They're all pretty good.
Well, there may be one or two duds in the bunch.
Well,
but
yeah, I guess.
Overall, we hope they're useful. We hope they help.
Okay, see you next time.
Take care.
Thank you for joining us today. This podcast was produced by Kaz and George. Music by Paul.
He's the best.
Contact us and send us your questions on Twitter at Mind Deconstruct.